these are basically fixed or stuck deformities. So if we can broadly kind of define deformities as flexible, rigid, or fixed or stuck, these are the congenital or prior fusion deformities where we're doing 3-column osteotomies. I like this subject because not only is it sort of near and dear to my heart, but a lot of times I get to involve my colleagues and friends in these cases, Sig, Shane, Lee, and others who have helped me with these cases. So this is a 30-year-old with severe Scheuermann's kyphosis. Typically, we think of Scheuermann's as a flexible deformity, but with long-standing deformity, we can see autofusion. In this case, he had anterior autofusion from T10 to T12, which is the apex of his type 2 Scheuermann's, and then posterior fusions more extensively. And interestingly, in this case, he actually had very severe spinal stenosis due to ossification of the yellow ligament. And so Dr. Tan and I undertook this case, navigated our screw placement just to save time and brain power prior to the osteotomy. In this case, actually required 2-level vertebral column resection. I think in terms of these complex cases, I always try to think about what the take-homes would be or what the most important teaching points would be. And I think with these severe deformities, root management and blood flow management to the spinal cord is probably the most important thing, other than, of course, getting the spine well decompressed before you start to move it. And so in these cases, we just took 2 roots and did temporary tying of the roots prior to resecting them. And then this shows the posterior wall impaction and both cantilever and rod exchange correction to get our correction over a cage. So I think take-home points here, number 1, avoid over-shortening, so we actually corrected over a cage. Number 2, preserve roots whenever possible, particularly at the thoracolumbar junction where our blood supply is compromised. And then in this case, we actually used a PJK prevention technique and did percutaneous fixation proximally to prevent excessive reciprocal kyphosis or PJK. And so this is his result here, and try to avoid overcorrection as well. Tattoo is fairly recognizable. So let's see. Let's go to this next case. So this is interesting. Congenital kyphosis in a healthy 12-year-old. Not as severe of a deformity, just a 52-degree focal kyphosis due to a posterior hemivertebra at L1. And so for this case, different ways to approach it, but who would think about resecting this? Resecting 3-column osteotomy. 1, 2. Who would think about trying to do this without a resection, just PCOs or some other strategy? Anybody go anterior then posterior? Okay, anterior then posterior. Tell us a little bit about how you'd approach it, anterior and posterior. So you do inner bodies. It sounds like trans or lateral approach, 12-1, 1-2. I love that idea, actually. Did you have any concerns about the footprint, kind of the anterior posterior length of the end plates at L1? Or do you think you have enough real estate to get a cage placed to the extrude? Nice. So in this case, actually found that he had some flexibility on his supine and push prone films. It's a fully segmented hemi, so we have some compliance of the discs that we can leverage as well. And actually just did all posterior here with Smith-Peterson osteotomies, and we're able to get it corrected. But I certainly think inner body work is a nice alternative as well. All right, this is tapping my next partner in crime, Dr. Bervin. So this is a 13-year-old with congenital kyphoscoliosis, had a relatively severe kyphosis and due to multi-level congenital anomalies from T9 to T11. Some moderate stenosis as well. So it's important to take into account where we need to, what the extent of our decompression needs to be before we start moving the spine, of course. In these complex congenital cases, I always make a model. So this is a model or a 3D reconstruction and then a model that we made to guide us in surgery. And this was prior to our obtaining navigation, unfortunately, at our children's hospital. So we use the model to help freehand technique for screw placement. It can be very disorienting, obviously, with these cases. So marking out pedicle start sites, trajectories, and kind of as much as you can on the model is important. And then we did a 2.5 level VCR and corrected over a vertebral body replacement cage. And patient's done well. Had some reciprocal kyphosis above his fusion that developed over time, but it's generally done well. Anybody do anything differently here? Would you? Yeah, I think sometimes you just have to resect it. All right, and one more. This is a case of a I believe 12-year-old who was initially treated in Mexico City with a posterior, at age 5 with a posterior instrumentation, some sort of attempt at guided growth for this more severe deformity. He actually was not frankly myelopathic, but did have very significant cord draping and cord compression. This is his standing X-ray. You can see his has some degree of a coronal plane deformity, but primarily this very acute kyphoscoliosis and then compensatory lumbar lordosis. He was placed into traction initially for about 3 weeks prior to instrumentation. So my approach for this was traction to get as much of his trunk lengthened as possible. We knew he wasn't going to move much over the apex because it was very rigidly autofused. But we were able to get him to gain some weight, get his lungs conditioned, get his spinal cord conditioned, and help get his sort of trunk just as lengthened as we could. Then placed, it was a little bit too much to try to tackle this all in one day, so placed instrumentation from I think it was C5 down to L3, and then put him back into traction for a couple weeks. And then used navigation to guide the 3-column osteotomy here. So this is, again, his preoperative CT, preoperative x-rays, his model showing the bayoneting of these severe congenital kyphosis cases as they progress tend to bayonet because of abutment of the anterior spine. And then a lot of planning, just given all of the congenital anomalies with that presented challenges for screw placement and such. Skip through a lot of that. I think one important tip just for trainees is try to plot out both your instrumentation, your construct, your correction technique, and kind of as much as you can, because chances are you're going to be fatigued or dealing with motor changes, and you don't want to be trying to think through how you're going to achieve something under that stress. So we sort of had a plan going in. And then this was my partner, Shane Birch, who's not here at the meeting today, but helped with the resection for this case for part 2. And one thing that is not talked about frequently, but is I think an important thing to think about, is where to start your osteotomy. And something I learned in fellowship with Larry Lenke is attacking the concavity first. That's where your compression is. As the spine starts to move and starts to creep, that's what's going to cause your motor change. So attacking that, the area where the cord is draped first, and then going from there. So a lot of images just to get you the flavor. And then this was the final construct. So was able to get reasonable correction of the congenital kyphosis, but being hypercritical, and if I was to do this case tomorrow, to give you a take-home teaching point is you really have to address the compensatory deformities before you start your correction. So I would probably have done Smith-Peets in this upper thoracolumbar junction and upper lumbar spine to flatten out the hyperlordosis prior, because this is contributing to a little bit of negative sagittal balance and a little bit of subsequent cervical kyphosis. So one last thing to think about is just, addressing and anticipating that your correction is going to require you to address those compensatory deformities as well. All right, so this is a case from last month. So a 12-year-old, otherwise healthy boy with congenital kyphosis. This is actually two hemivertebrae. Move my mouse around here. Two consecutive hemivertebrae that were leading to about a 70-degree congenital kyphosis. This is his clinical appearance on the operating table. And the plan here was, again, he has this severe deformity, but it's at the thoracolumbar junction, so conserving lumbar levels, I think, is one of the key goals here. Interestingly, the pedicles at the hemi were cannulatable, so we could actually use the anatomy here for fixation. And so initially, when I thought about this case, I was planning to do a 2-level VCR, but we ended up just resecting the more cranial hemivertebra, and I'll show you how that went here. So did construct to construct correction using side-to-side connectors and kind of controlled compression of construct to construct with final correction over a T-lift cage. And so we instrumented the lower, as you can see on the right, the lower hemi was instrumented. Screws were left a little bit proud to allow us to push that vertebra anteriorly. And then prior to the final 20 degrees or so, we placed actually the smallest available T-lift cage, not only to get continuity of fusion anteriorly, but to allow us to correct over that fulcrum and augment the correction. And so this is the result, his clinical appearance on the table. And I think effectively we're able to save a level versus what we likely would have had to do if we took both vertebrae out. So again, being hypercritical, probably should have ran a 4th rod here, just given that it's 3-column instability, but he's doing well.
Now, when you do a construct connection, when do you change out one of those rods to a primary rod rather than leaving the construct?
Yeah, it's a great question. So in this case, I think there's different philosophies. I think depending on how many times you do in situ. So what we did with this construct to construct is always had the rod engaged in the side connectors proximally and distally. So didn't use any sort of free cantilever maneuvers, because I think you can certainly end up with translation or rotation across your osteotomy, which can lead to neurodeficits. So what we did was, one at a time, would remove one of those satellite rods, under contour it, or take some of the kyphosis out of it, re-engage it, and then compress. So compress bilaterally each time. I think that's a good controlled way, so you're never sort of swimming without a destination there, and you always keep control. Yeah. Lee.
It's a great result. Question for you is that what do you typically do with the lumpectomy defect afterwards? Do you just block the process, or do you use like allograft to cover the site?
Yeah, it's a great question. There are times where I've used a long allograft rib and just kind of bivalved it and covered the dura from lamina to lamina, the lamina above, lamina below the laminectomy. In this case, we didn't do that, just covered the dura with sort of a third rod to give a little bit of soft tissue protection. But yeah.
I think, for the cases we've done together, covering it with a wooden rib is really nice to kind of provide a barrier
Yeah.
to the bone graft. Like, otherwise, you dump a bunch of bone chips or whatnot, it can be,
Yeah.
oppressive.
Yeah. Yeah, no, I completely agree. I think that's sort of ideal, is having bony coverage over the dura. This case, we didn't do it. All right, everybody. Thanks very much.